we will review the study guide. I'm going to put it on the screen in a second. So, you all have study guides in front of you, right? Now, a few things I want to say before we talk. As I say usually, my intention is not to answer every single question, but I will give you an idea what the questions are going to be focused on. Okay? So, this thing shows up. Basically, anatomically, when we talk about the heart, you need to understand the position, you need to understand the base and the apex and apical impulse, like the heartbeat, okay? Pericardial layers. Know the difference between the fibrous pericardial, parietal pericardial, visceral pericardium, okay? Know which two are separated by the cavity, okay? So parietal pericardium covers the cavity, visceral pericardium covers the heart, right? And between them there is a space filled with fluid. Okay? Good? So far. So I will kind of clear it up out of the way. Inflammation of layers. Remember pericarditis? So know what pericarditis is. Inflammation of pericardium. Myocarditis, inflammation of muscle. Endocarditis, inflammation of endocardium, mostly valves. Does that make sense? I'm not going to ask you about like which microorganism out of these four can cause myocarditis. Don't worry, it's not a microbiology class. Am I clear? Remember that in pericarditis, fluid volume can increase, and that may lead to the tamponade, right? Remember? And that accumulation of fluid will prevent heart from contracting and, relaxing properly. Friction rub is when inflamed pericardium becomes thickened and visceral and parietal layers start to rub against each other. Okay? So far. So epicardium is pericardium, myocardium is muscle, endocardium are endothelial cells that line the heart from the inside, the chambers of the heart. Structures. So what happens to cardiac valves when they're inflamed? They do not close properly. Okay. Now, here, the function of auricles. You kind of see that I'm skipping a lot right now. I'm going to tell you why. The function of auricles is to enhance the volume of the atria, right? Fossa valis is the remnant of the foramina valli that exists in the fetal heart during the development. Speaking of atria, ventricles, blood flow, we can basically just speak it out now. So right atrium receives blood from vena cava, from systemic circulation. It is low in oxygen. Then blood flows from right atrium through the tricuspid valve to the right ventricle. From right ventricle, it enters pulmonary circulation via pulmonary trunk and pulmonary arteries. Blood gets oxygenated in the lungs, returns back to left atrium enters via pulmonary veins. From left atrium, it enters left ventricle via mitral valve, and from left ventricle, it goes into aorta. A few things that we didn't mention. Valves between atria and ventricles are often referred to as atrioventricular. Valves between the ventricles and the circuits are semilunar. Okay? In the right ventricle, semilunar is going to be pulmonary. In the left ventricle, semilunar is going to be aortic. If you can do this cycle, and if you know whether it is... Okay, so in the right chambers, blood is oxygenated or not? No. In the left chambers, oxygenated. If you can draw the blood flow through the heart, we're talking like 4 or 5 questions. Does that make sense? And absolutely draw it. Does that make sense? So I'm not gonna go over this again. We just went through the blood flow. Does that make sense? Same goes for ventricles. Oh, separation. Atria is separated by the interatrial septum. Ventricles are separated by interventricular septum. Okay. Coronary and interventricular sulci. What lies in those? Coronary blood vessels, coronary arteries. That's as far as it goes. Trabeculae carnae are the ridges on the surface of the ventricular walls. Chordae tendinae are the hair-like structures that attach atrioventricular valves to the papillary muscles. And papillary muscles control closing and opening of the valves. We just covered it. Everybody sees that. It's kind of reiteration of what we just said. Should you feel it out? Abso-freaking-lutely. Feel it out. You know, make sure that it goes almost on the reflex level. Tell you which blood vessel leaves right ventricle. Pulmonary trunk. I tell you which blood vessel leaves left atrium. You tell me, dude, you're crazy. None. There are no blood vessels that leave left atrium. Does that make sense? They only enter. So valves. Okay. Difference between arteries and veins in terms of the direction. Arteries go away from the heart, veins towards. Do veins always carry oxygenated blood? So pulmonary veins carry oxygenated blood, pulmonary arteries carry deoxygenated. That's the exception. Valvular stenosis, narrowing down of valves. Okay? When valve becomes incompetent, means that it doesn't close completely. Okay. What are the treatment options? Replacement. What happens if the valve is incompetent? Blood regurgitates back. Okay. Again, blood flow, we got it. Blood volumes. Okay. Blood volumes in pulmonary and systemic circuit are the same. Pulmonary circuit oxygenates blood. Systemic circuit delivers oxygen to the tissues. Pulmonary circuit is shorter with lower blood pressure and lower resistance. Okay? Pulmonary arteries are generally thinner than systemic arteries. Okay? Because pressure. What happens when there's a mismatch? Congestive heart failure. Remember? When one side fails to pump, if left side fails, which congestion are you going to have? Pulmonary congestion. If right side fails, systemic congestion. We cool? Coronary circuit delivers blood to the heart muscles. Coronary arteries arise from aorta. Left coronary artery supplies basically left side, and right coronary artery supplies the right side. Okay? Where does the most coronary supply go? Which part of the heart? Left ventricle. Because it's big and the muscle is thick. Anastomosis. Connection between two blood vessels. Importance, provide collateral route for the blood. Angina pectoris. It's decrease in coronary blood flow. Transient decrease. Myocardial infarction. Lack of blood flow to the cardiac muscle. Causative causes of myocardial infarction. No, that's the consequence. What can cause myocardial infarction? Clot. What else? Sudden constriction of blood vessels, coronary blood vessels, coronary atherosclerosis, or basically a mismatch between the supply and demand. Okay? Now, as Lexi mentioned, the consequence is what? Cells die. Say again? Perfect. Cells die, replaced by connective tissue, is the scar tissue, and connective tissue can't contract, so cardiac contractility decreases, and heart doesn't work as it's supposed to. So okay. Cardiac muscle contracts involuntarily. Cells are striated because they have sarcomeres. Cardiomyocytes, they branched, yeah, they are. And it's kind of a... cardiomyocytes, are they connected by gap junctions? Yes, they are. How many nuclei are in the cardiomyocytes, CMC? Usually one, sometimes two. The function of the intercalated discs, they can contain two things. They contain gap junctions and desmosomes. Gap junctions provide communication. Desmosomes hold cells together. We good? Okay. That's it. Desmosomes hold cells together. Gap junctions are ion channels. So CMC are striated because of the sarcomeres. Calcium, what does it do? It binds to troponin. When it binds to troponin, troponin removes tropomyosin from actin, and then actin and myosin can establish cross bridges, right? And then you have sliding filament model of contraction. Okay, so cross bridges between actin and myosin. Sarcoplasmic reticulum releases calcium. T-tubules deliver action potential to the cells. Cross bridge between actin and myosin. Which molecule is absolutely required for cross bridge cycle? ATP, when it is broken down, cross bridge coax back, and when ADP and phosphate are released, slides the filaments. In order to detach myosin molecule from actin, myosin has to interact with what? Again, ATP, right? So ADP allows that detachment. Okay, depolarization of cardiomyocytes is due to the, what I want you to tell me now, let's do it in a good, quick fashion. Ion and influx or efflux. Depolarization of cardiomyocytes. Influx of sodium. When cells are depolarized, what happens to voltage-gated sodium channels? They inactivated. They closed and inactivated. So calcium channels, they slow, right? Where does calcium go? In. What does it maintain? Plateau, action potential, right? So plateau is due to the calcium, right? And then calcium channels eventually close. Which channels are open? Potassium. Potassium goes out, so efflux of potassium. Absolute refractory period is when sodium channels are inactivated, right? It doesn't let the cardiac muscle to go into tetanic contraction. Does that make sense? Metabolic requirements of cardiomyocytes. What they can use as a fuel. One word starts with E. Everything, yeah. I mean, of course, glucose is best. They can use lactic acid, they can use pyruvate, they can use lipids, they're fine. They can use any type of fuel, okay? What type of metabolism they prefer? Aerobic, because it gives you more ATP. What happens to them in ischemia? Lactic acid's formed. Mitochondria, they damaged. What happens to calcium? It increases, ATP production decreases, gap junctions close, lack of communication between the cells, and you have arrhythmias because gap junctions keep heart beating correctly. That makes sense? So pacemaker, that, remember the pacemaker potential? This one, what forms it? Sodium channels. This one. Huh? Calcium channels. This one. Potassium channels. So, sodium and calcium go into the cell, potassium flows out of the cell. That makes sense? So that's the threshold. You have action potential when the pacemaker potential reaches the threshold, cell depolarizes, sends the signal. Okay? So we kind of got this. When cell reaches action potential, what happens to calcium channels here? At the peak. They close, yeah. Closed and activated, yep. When cell is completely repolarized, potassium channels close. Does that make sense? Okay, which structures support communication between cardiomyocytes? What cardiomyocytes are connected by? Junctions. Which junctions? Gap junctions. Connect cardiomyocytes. Conduction system of the heart. Anybody volunteers to go through it? I know you know it. Come on. SA node. AV node. AV bundle. Bundle branches. Purkinje fibers. SA node is the pacemaker node normally, right? What's the intrinsic rhythm of SA node? Intrinsic. 100. AV 50. And if you go down to bundle branches and Purkinje fibers mostly, about 40, okay? We'll get to the... so SA node is in the right atrium. AV node is very close to the atrioventricular septum, pretty much between the atria and ventricles, like in the wall. And then AV bundle and bundle branches are in the interventricular septum, and Purkinje fibers are in the ventricular walls. Inherent grades, we got it. Atria and ventricles, what are they connected electrically? By only AV bundle. What is the importance? Why it's important? Impulse is delayed, so atria and ventricles contract at different time. Does that make sense? So impulse is delayed? Yeah, got it. Okay, ECG. What does it measure? Electrical impulse to the heart. P wave. What is that? Depolarization of the atrium. QRS complex. Ventricular depolarization, atrial repolarization, overlapping. T wave. Repolarization of the ventricles. PR interval. Atrial depolarization to ventricular depolarization. ST segment. Ventricular ventricle is depolarized. QT segment. Say it one more time. It's from the start of ventricular depolarization to the end of ventricular repolarization. Okay. Now, heart rate. Why it's not 100? Parasympathetic system slows it down, right? It inhibits cardiac conduction system. Tachycardia. High heart rate. I'm not going to ask numbers. Don't worry. Like, I'm not going to ask you. 98. Is it tachycardia or not? Well, if my normal is 40, yeah. Bradycardia. Slow heart rate. Are tachycardia and bradycardia abnormal? Like, if I tell you, is it bad by itself? Like, tachycardia is bad. Bradycardia is bad. Neither. If I'm running or exercising, I have tachycardia. If I'm well-trained athlete and I'm sleeping, I have bradycardia. That's it. Okay? Now, bradycardia can be caused by the drop in blood pressure. Tachycardia can be caused by various stimulants. That makes sense? SA block. If there is an SA block, what you don't see on the EKG, huh? P wave is gone. Which node takes over? AV. How do we call the rhythm that is set by AV node? Junctional. Rhythm that is set by SA node is normal rhythm, sinus rhythm. Okay? Can SA block happen in the healthy people? Yeah, it's fine. Actually, yeah, I spoke to one of my doctor friends and they said, if you put person in ECG and we'll observe it in real time, 5-10 minutes, and you're going to see SA block. It's going to happen. Same for AV, for the heart block. Okay, the AV block. So in the first degree AV block, dropped bit, like, right? Second degree AV block. I remember it's every second dropped bit. Huh? Yes. And the third degree, it's complete heart block. What takes over in the third degree AV block? AV node, or more frequently bundles. Okay. Now, if bundles are blocked, if like complete, there is no transmission of signal from atria to ventricles, what takes over? bundle branches or Purkinje fibers? What is the intrinsic rate for those? 40. Is that sufficient for a regular fellow? No. How do we treat it? Pacemaker. Does that make sense? Ectopic focus. Accidental pacemaker. Perfect. Great idea to formulate it. Can it be in the normal person? Where is it usually located? Atria, ventricles. Atria. If it's in the ventricle, that can be a big problem. Okay. So what happens when impulse returns to the atria from the ventricles? Can actually cancel it out. Okay. Can these events happen in the healthy patients? Yes. Actually, it causes premature contractions, right? Can be caused by coffee, nicotine, any type of stimulant. What are the risk factors for the premature contractions? Previous myocardial infarction. If we talk risk factor. Premature atrial and premature bundle contractions reflected on ECG have an extra beat. Okay. Premature ventricular contraction. Causes are same, basically. Okay. I'm not going to ask you that the T wave is inverted. We're not getting that deep. It is inverted, but not getting deep. Okay. Now, if somebody has a premature ventricular contraction, is that a predictor for something? For VFib, yes. So atrial fibrillation. Basically, what is fibrillation? Uncoordinated contractions. Which one is deadly? VFib. How is it reflected on ECG? Huh? Shaking, yeah. So basically waves without any particular order. AFib, what would you see? You will see regular rhythm, but you will see parts of QRS complex, right? And you will see T wave. You won't see probably P wave, normally, okay? Clinical complications associated with AFib. Clots, stroke, not right away. Decreased heart pumping. Basically, you're going to have a patient with lower end diastolic volume. What happens to a patient with VFib? In like 95% cases, they die. Okay, that was actually interesting statistics. Turns out that you know how in movies when they do CPR on victims, the victim like stands up and starts to breathe. 95% of cases in real life, cases that require CPR, 95% of patients die. Ventricular fibrillation, shock, electric shock. Okay. Okay, cardiac cycle. I don't want to answer specific questions because it will take too much time. I want to go over the cardiac cycle with you. Like, we're going to start with first step. What is the first step of cardiac cycle? Everything is relaxed. Blood flows freely. We're going to talk about left side if you don't mind, just easier, okay? Blood flows from pulmonary veins into the left atrium, basically directly from left atrium into the left ventricle through the AV valve, through the mitral valve. So mitral valve is open. SL valve is closed. There's no contraction happening. Pressure in the ventricle is highest, lowest in the middle. in the ventricle. Lowest. Because the valve from atria to ventricle is open, which means atrial pressure is bigger, right? And the valve from ventricle to the aorta is closed, which means aortic is bigger. We good? Then we have T wave. What happens to the atrium? Contracts. What's the purpose of that contraction? Push the rest of the blood into the left ventricle. As the blood is pushed in the left ventricle, what happens to the pressure in the left ventricle? It rises. That rising pressure closes AV valve, mitral in our case. So at this point, that's the first sound of valve, right? The lub sound. AV valve closes. Now the pressure in the ventricle is highest, lowest, in the middle. In the middle. Because semilunar is still closed. Aortic pressure is still higher than ventricular. But ventricular is higher than atrial. Does that make sense? Good? What happens next? Which stage? Isovolumetric contraction. Isotonic contraction. Well, kind of is. You know, muscle kind of shortens. So isovolumetric contraction. What happens to the pressure, to the volume of blood in the ventricle? Does it change? No. What happens to the pressure in the ventricle? It increases, and when is sort of a threshold? When it increases over what? Aortic pressure, what opens? Semilunar valve. And blood starts to flow into the aorta. The ventricular contraction corresponds to, roughly, to what part of ECG? QRS. Yeah, it's basically QRS. Okay? So blood goes in the aorta. At this point, during the ventricular ejection, pressure in the ventricle, highest, lowest, in the middle. Highest. Pressure in the aorta builds up. When the pressure in the aorta becomes what? Higher than in the ventricle, what happens? Semilunar valve closes, okay? And what starts? Isovolumetric relaxation, okay? So ventricle relaxes and pressure in the ventricle decreases until it becomes lower than in the atria. At this point, AV valve opens and blood flows into the ventricle. And it all starts again. That makes sense. A closure of a cell valve, it's a dub sound. That makes sense? If you can kind of draw it, whatever way you want, if you know the position of valves during each stage, the pressure relationships during each stage, you'll be totally fine. I promise. Okay? And you know where blood goes. So don't tell me that during ventricular ejection, blood goes in the atria. It doesn't. Okay, we're good? So I'm going to basically skip this. Okay. Cardiac output. I'm skipping all the questions in the cardiac cycle. I still encourage you to fill them out meticulously, step by step. And I know a lot of you did that already, but I encourage you to do that if you didn't. Exams on Monday, obviously. What are we doing here? Oh, cardiac output. Yes, sorry. I have, like, the entire day I have brain freezes every, 10 minutes. So, volumes. This is the equation that you need to know. If you know this, cardiac output equals heart rate multiplied by the stroke volume, which is the difference between end diastolic and end systolic volume, you find cardiac output is equivalent to the volume of the blood pumped in a minute, right? That's the definition of cardiac output, right? What's the cardiac reserve? Difference between the maximum cardiac output and resting cardiac output. Does that make sense? Okay, that's as far as it goes. Now, let's play with this equation. What can change heart rate? What types of stimulation? So, sympathetic versus sympathetic. Parasympathetic. If you increase heart rate, what happens to cardiac output? Increases. Decrease it? Decrease. When? Now, to make it very clear, either now or in the exam, when I have a question, if you increase/decrease something, the presumption is that everything else remains the same. Does that make sense? Because think about this. If my heart rate now would magically decrease, normally, physiologically, what would immediately increase to maintain my cardiac output stable? And diastolic volume. Thank you very much. Does that make sense? However, in the exam, when I ask you, what happens if heart rate goes up, you presume that everything else remains the same. Am I clear? Okay? Deal? So it's a 100% presumption. So we can regulate the heart rate. And diastolic volume. If it increases, what happens to cardiac output? Increases. And systolic volume. If it increases, what happens to cardiac output? Decreases. Because what decreases? Stroke volume. Correct? So what can increase? Let's talk about preload, afterload, and contractility. What is preload? Increased force of contraction when cardiac muscle is stretched. Okay, so basically it means that if you have more blood pumped in the heart or delivered into the ventricle before the ventricular systole, due to the increased force of contraction, nevertheless, all that blood will be squeezed out in the circulation. Does that make sense? Okay. So, what increases preload? Two main things. What can increase the preload? So again, longer diastole, so lower heart rate. And what else? Where does blood come from into the heart? Veins, just veins. So what will increase the preload? Venous pressure, venous return, okay? Like muscular pump, respiratory pump, if they will squeeze harder, squeeze more, venous return will go up. Does that make sense? Now, increased venous return or lowered heart rate will increase end diastolic volume, right? Contractility. What is this? Force of contraction at the given length, period. So if you will increase contractility of the cardiac muscle, which parameter you will affect? See it? And systolic volume. How? If you increase contractility and systolic volume, will go down. You squeeze out more, leaving less blood in the heart. That makes sense? So basically, no, play with this thing. And finally, afterload. What is this? Pressure in the circuit. Okay, pressure that ventricle has to work against. Increased afterload will affect which volume? And systolic, how? It will increase it because heart will not be able to squeeze it out. Does that make sense? There will be another 5 or 6 questions that will deal entirely with the effects of venous return, afterload, contractility on the cardiac output, stroke volume, and things like that. If you can play with this formula, you're totally fine. Am I clear? Okay, sympathetics. Sympathetic stimulation. How does it affect heart rate? Increases. May we skip cardiac output? I presume that you can figure it out. Okay. So sympathetic stimulation increases heart rate. Does it affect contractility? Yes, increases it. Parasympathetic stimulation decreases. No. It's no effect on contractility. It only decreases heart rate. Okay. Huh? Good. 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 So heart rate, yes. But parasympathetic system has no effect on the contractility of the heart. That makes sense? So increased blood pressure equals increased afterload, right? Increased systemic blood pressure means increased afterload. We got this. Change in the heart rate may affect venous return. Preload. Contractility. Okay. Ionotropic agents. The ones that I can and probably will ask you about. Calcium, epinephrine. Oh, come on, potassium, for God's sakes. Again, calcium. Potassium, okay? So no effects of calcium, epinephrine, and potassium for sure. Calcium and epinephrine, are they positive or negative inotropic? Positive. Potassium, negative. Meaning positive increased contractility, negative decreased contractility. We good? So we got this afterload thing. Sympathetic and parasympathetic on the heart rate. Agents that increase heart rate are positive chronotropic. Calcium and epinephrine are positive. Potassium is negative chronotropic. What about ACH? Negative chronotropic. Perfect. We good? Like, look, know the effects of exercise, please. But it's sort of obvious. You know what exercise does to your heart, right? Congestive heart failure. Left side fails, congestion is in the pulmonary system, what you may expect. Pulmonary edema. Right side fails, congestion in the systemic, what you can expect. Peripheral edema, you can expect portal hypertension, you can expect hepatosplenomegaly, all those pathologies associated with higher blood volume than normal in the systemic circuit. So atherosclerosis increases what? From the height of your knowledge now. Atherosclerosis. What does it increase? What does it affect? Blood. Affect. Let's start. Blood vessels. How? What does it increases? Does it increase? Peripheral resistance. When it increases peripheral resistance, it increases blood pressure. High blood pressure. It's bad for you because it increases inflammation. It increases afterload. And it generally causes vasculitis, inflammation of the blood vessels. We still don't know the mechanism, by the way. People get enormous amount of money for that. Dilated cardiomyopathy. Heart cannot squeeze out the blood in the volume that's required, right? So you have an enlarged ventricle with a fairly thin wall, okay? Muscle is not enough to squeeze the blood out. Myocardial infarction, Lexi told us, the wall cannot contract, okay? So alveolar macrophages, don't worry about, the macrophages with traces of iron in them. Pulmonary edema, liver, hepatomegaly, splenomegaly, coronary disease, cardiac tamponade, pleural effusion into the peritoneum, pleural and pericardial effusions. Basically, fluid starts to seep everywhere in the system, in the tissues or in the cavities, like peritoneal cavity, pleural cavity, or pericardial cavity. Does that make sense? Treatment options. Yeah, remove fluid, increase play with the contractility of the heart, ideally do the heart transplant. Atria are connected by the foramen ovale. Why it's not pathology that atria are connected. Why? Fetus doesn't breathe with the lungs, right? Okay, septal defects. I'm going to be very clear what I expect you to know. You need to know that can be interatrial septal defects and ventricular septal defect. That's it. Patent ductus arteriosus means that aorta and pulmonary trunk are connected. The general outcome of all those septal defects is the mixing of oxygenated and deoxygenated blood, which in general leads to cyanosis. In tetralogy of Fallot, what I want you to know, there's a septal defect. Sometimes there's patent ductus arteriosus. There's stenosis of pulmonary trunk. Okay? That's as far as it goes. Transposition of great arteries. 2, you need to know that it's incompatible with life because 2 circuits completely isolated. We clear? I mean, you have no oxygen going into the tissue at all. Does that make sense? So pulmonary trunk, where would it originate in the transposition of great arteries? In the left ventricle. That makes sense? And the aorta will originate in the right ventricle. Coarctation, stenosis, atresia. So what's coarctation? Generally. Narrowing. Pretty much another name for stenosis. Narrowing. What is atresia? It's hypoplasia, just generally. Hypoplasia. So atresia is basically very, very small aorta. Does that make sense? That's as far as it goes. General symptoms, basically all of them. I mean, if you think about coarctation of aorta, what you're probably going to expect is the lack of proper blood flow to the lower limbs. So you're going to have low blood pressure in the lower part of the body and increased blood pressure in the upper part. Because blood cannot reach it, will be redirected basically in the brachiocephalic trunk and left carotid and left subclavian. Does that make sense? But what you need to know that impaired blood flow. That's as far as it goes with the general symptoms. Age changes. Know that with age, walls of the heart become thicker, coronary arteries become more sclerosed, there are depositions of fat, atheromas, valves valvular stenosis. Okay. Left ventricle with age becomes smaller because the walls become thicker. Thus, aorta with age, usually walls become thicker and the lumen becomes small. Okay, so you have to understand that with age, blood vessels become generally narrower and the heart becomes weaker. Okay. Tunics. Intima, media, externa. What you need to know, main structures in intima, endothelial cells, in intima, smooth muscle cells, in externa, connective tissue, as far as it goes. Types of arteries. Know the difference between elastic, muscular, and arterioles in terms of the function. Which ones buffer the blood flow, the fluctuations of the blood flow, which ones can constrict, which ones are resistant, hint, arterioles, so they regulate blood flow to the tissues. And understand, like, does aorta regulate blood flow to the tissues? No, it doesn't. Okay? Does that make sense? Because it's too big. Elastic arteries do not regulate blood flow to the tissues because they have basically no vasomotor responses. Okay? Veins, postcapillary venules, just venules, and veins, and sinuses. Sinuses are flat veins that can be found in the coronary circulation and cerebral circulation. Postcapillary venules are small. Can veins, large veins, constrict? Yes, weakly. What does it mean that they capacitance vessels? They store blood. I told you where the sinuses. What is the function of venous valves? Prevent the backflow. Does that make sense? 3 types of capillaries. Know the relationship, okay, between least permeable, continuous, medium permeable, fenestrated, and most permeable, sinusoid. Am I clear? I'm not going to ask you about the structures that enable transport, but I definitely going to ask you about this. What's the word? Ability, like permeability. And be able to tell where they are. So if I ask you, what you're going to find in muscles, you tell me that's going to be continuous. What you're going to find in liver, you're going to tell me those are sinusoids. Okay? Again, I'm not going to throw a curveball at you with this. Capillary diameter is determined by the diameter of red blood cell, function of the tight junction, to control the transport from capillary to the tissue. Capillary bed, capillaries that perfuse the tissue. It is supplied by meta-arteriole and drained by postcapillary venule. Vascular shunt connects the arteriolar side and the venular side, right? What controls the blood flow through the capillaries? Capillary sphincters. If they open, you have blood flow through the bed. If they close, blood flows through the vascular shunt. We talked about anastomose. Got this. Okay. Does that make sense? Can you see the equation? And since we're talking about systemic blood pressure, what can we substitute blood flow with? Cardiac output. So this is how you regulate blood pressure. Increase or decrease cardiac output, increase or decrease peripheral resistance. Okay? Blood volume, how does it relate to blood pressure? higher blood volume, higher blood pressure. Blood flows from high pressure to low pressure. Remember, it's a gradient. Peripheral resistance. What can affect peripheral resistance? Body size, turbulence of flow, diameter of the blood vessels, and viscosity of the blood. Which parameter can you change instantly? Diameter of the blood vessels by dilating and constricting. Okay? 4 factors. Don't memorize that it's, 1 divided by radius in the power of 4. I don't really care that much. But you have to understand, if you dilate blood vessels, peripheral resistance will decrease. If you constrict blood vessels, it'll go up. Does that make sense? Okay. Are you comfortable with the terms inversely proportional and directly proportional? Okay. You're comfortable. Everybody's comfortable with these terms. We're good. If you're not comfortable, tell me, I'm not comfortable. We're all good. Don't hesitate. There's nothing embarrassing about it. Okay? Good. Okay. Yesterday we were doing like 2 in the power of 1, 2, and 3, and we spent like 20 minutes in another class figuring out how to put 2 in the power of 4. So we're good. Highest blood pressure is where? Aorta. Lowest? Right ventricle. Because it still needs to go from vena cava to the atrium, and then it can completely relax. Right? Steepest drop. Arterioles. Systolic pressure is the pressure when heart contracts. Diastolic is when it relaxes. Pulse pressure is the difference. Okay? How do we calculate mean arterial pressure? Diastolic plus 1/3 of a pulse. Okay? If blood pressure in capillaries, well, let's skip this for now, okay? We'll get back to this. Blood pressure in capillaries, we'll get to this. Okay? What increases venous return? Muscular pump, respiratory pump, venular constriction. What are the main things for venous return? Main things. Realistically speaking. Muscular pump. Respiratory pump probably will go second. Does that make sense? So, in increased blood pressure in exercise, you have increased venous return, you have increased, now think about this, in exercise, what happens to cardiac output? Increases, blood pressure goes up. That's it. This is another equation that you should be able to play with. Sympathetic activation, how does it change the cardiac output? Increases, blood pressure goes up. Okay, let's do the reflex arch. Blood pressure changes. I deliberately don't say increases or decreases. Blood pressure changes. Which structures sense it? What type of receptor? Chemoreceptors, osmoreceptors, mechanoreceptors. They sense stretch. Blood pressure goes up, stretch goes up. Blood pressure goes down, stretch goes down. That signal, where does it go to? Medulla oblongata. Medulla oblongata. Which centers are there? Cardioacceleratory, vasomotor, and cardioinhibitory. If blood pressure goes up, which centers are inhibited? Acceleratory and vasomotor. Which center is stimulated? Cardioinhibitory. If blood pressure goes down, acceleratory and vasomotor stimulated, cardioinhibitory is inhibited. Cardioacceleratory and vasomotor, which branch of ANS controls them? Sympathetic, cardioinhibitory, parasympathetic. So, cardioacceleratory center, what does it do? increases heart rate and contractility. Cardioinhibitory center, what does it do? Decreases the heart rate. Vasomotor center, what does it do? If it's stimulated, it constricts the blood vessels. If it's inhibited, blood vessels dilate. Does that make sense? When blood vessels dilate, blood pressure goes down. When blood vessels constrict, blood pressure goes up. We're clear? Please know that. Know like the inhibition of such center or such center. Does that make sense? Okay, blood pressure control. What will increase the systemic blood pressure? I ask about CO2, oxygen, pH. What will increase blood pressure? CO2 should be, it's all high or low. CO2 in the tissues, high. CO2 is high, blood pressure goes up, blood flow goes up. Your CO2 is taken out of the system. Oxygen, low, it's like a least important thing. And then pH should be low, so acidosis. Does that make sense? All you need to know. These three things. It should be like solid, okay? Got it? Hypothalamus. When you start to exercise, hypothalamus increases blood pressure, increases cardiac activity, basically immediately. Does that make sense? It stimulates, hypothalamus stimulates medulla. Medulla, oh, okay. Epinephrine, norepinephrine, they stimulate vasomotor cardioacceleratory and increase blood pressure. Angiotensin II and ADH, what do they act mainly? Blood vessels. What do they do to them? Constrict. ANP, atrial natriuretic peptide, dilates. Weak vasodilate. Yeah, and decreases blood pressure. Absolutely right. Two renal mechanisms of blood pressure control. Direct blood pressure increases. Perfusion of kidneys increases. Urine production increases. Blood volume decreases. Blood pressure goes down. Opposite, you just flip everything. Indirect renal response. Blood pressure goes down. What happens to renin? Gets activated. Activated renin activates angiotensin 1. Angiotensin 1 activates angiotensin 2, and angiotensin 2 activates, well, leads to release of aldosterone. ADH is separate. ADH is hypothalamus. ADH deals directly from hypothalamus. Aldosterone, what does it cause? Retention of sodium, which is followed by the retention of water, which is followed by the increase of blood volume and then blood pressure. ADH directly decreases urine production, period. Separate mechanism. That make sense? Good. ACE inhibitors, what do they inhibit? Angiotensin converting enzyme. They pretty much stop RAS, renin, angiotensin, aldosterone system in the middle. Okay, and they treat hypertension. Okay, muscular pump increases what? Venous. Venous return increases end diastolic volume, increases cardiac stroke volume, increases cardiac output, increases blood pressure. Increased respiratory pump. One word, 4 letters, starts with S. And it's a good word. It's the word save. Okay? muscular pump, respiratory pump have basically the same effects. Does that make sense? A and P, what does it do? Two things. Blood vessels, it dilates them. What does it do to the sodium? We excrete sodium, natriuretic. When sodium leaves the body, what follows sodium? Water. What happens to the blood volume? Goes down. So pressure decreases. Activation of renin. We just went through it. Pressure goes up. Hemorrhage. How does it affect blood pressure? Goes down, of course. Dehydration. Initially goes down. Exercise. Up. Angiotensin II. Up. For two reasons. Eventual aldosterone activation and vasoconstriction. Increased body size. Up. Antidiuretic hormone. Increases due to the vasoconstriction and water retention. Epinephrine, norepinephrine. Increase due to the increased cardiac output and increased peripheral resistance rate. Does that make sense? With the blood pressure measurements, how do we measure the cuff? You understand what happens when cortical sounds appear. What do you measure? Systolic pressure, because at that time blood starts to go through. When they disappear, diastolic, because now there's no resistance to blood going through. Clinical hypertension, 140 of 90. Okay. Normal 120 over 80. Between those, pre-hypertension. Risk factors for primary hypertension. Poor life choices. Okay. I'm a nice guy, really. I will tell you something during the break about hypertension, conditions like hypertension, type 2 diabetes, and other stuff. Secondary hypertension is due to something else. Best example is like Cushing's syndrome. Increased production of cortisol leads to elevation of blood pressure. Right? Hypertension is lower than 90/60. Okay. Chronic hypertension, Addison's, for instance. Okay. Acute hypertension, shock, or orthostatic hypertension. So, hypovolemic vascular cardiogenic shock. Okay, hypovolemic. When does it happen? You lose blood. Vascular shock. Vasodilation. Cardiogenic. Cardiac insufficiency. When the heart cannot pump. Okay, when you lose a lot of blood. Let's talk about blood loss. So you lose blood. What happens to the blood volume? It goes down. What are the responses that are triggered? Heart rate goes up. Blood vessels, constriction, dilation. Unimportant blood vessels constrict. So, unimportant means skin, kidneys, probably digestive. Okay? So, since kidneys, blood vessels constrict, urine production practically ceases. Okay? Since your skin vessels constrict, how do you look? Pale. When you lose blood, ability of blood to remove CO2 from the tissues decreases, so CO2 accumulates in the tissues, have acidosis. How do you get rid of CO2? Huh? Breathe it out. So your breathing rate and depth go up. Decreased blood pressure, activate renin-angiotensin aldosterone system, and ADH. ADH conveniently keeps fluid in and it causes thirst, so you want to drink. And if you compensate with drinking, you're fine. Okay, you restore blood volume and eventually you'll be fine. Does that make sense? What happens if you don't restore blood volume and you lost a lot of blood? You die because of hypoxia and hypovolemic shock, right? Because blood doesn't get enough oxygen because blood pressure is so low, right? So we covered it all. ADH is released from hypothalamus. Well, low urine, restore blood pressure. So until, if you drink and you restore your blood pressure, it's negative feedback. But shock, whether it's hypovolemic shock, cardiogenic shock, or vascular shock, what example? Is that positive or negative feedback? That's typical positive feedback. Blood flow to the tissue. What regulates? Yes. Tissue needs. So tissue, it's not systemic blood pressure, right? It's not heart. So local blood vessels. Capillaries have the slowest rate for the exchange. Which blood vessels actually regulate the blood flow? Arterioles the most, yes. Maybe a little bit of muscular arteries, but to the organ, muscular arteries. To the tissue, definitely arterioles. So, systemic blood pressure regulation attempts to maintain blood pressure constant, stable. Does that make sense? Local perfusion should comply with tissue needs. So, local blood flow and blood pressure can actually alter quite a lot. Does that make sense? Okay, elevated CO2. The next statement should be increases local blood flow, decreases local blood flow. So, let's start again. Elevated CO2 increases local blood flow. Elevated oxygen decreases local blood flow. Elevated pH decreases local blood flow. Elevated potassium increases local blood flow. So, these three products of metabolism, elevated potassium, elevated adenosine, elevated prostaglandins, all increase local blood flow because they are the signs of metabolically active tissues. NO increases, it dilates the blood vessels. We didn't talk about endothelin, so I'll cross it out. Okay. How does myogenic control work? When blood vessel is stretched, what is the response? Constricts. If blood pressure drops and it's not stretched, it dilates. Angiogenesis is what? It's a growth of new blood vessels. Does that make sense? So in long-term perspective, how does angiogenesis regulate blood flow? Come on. If you grow new blood vessels in the tissue, blood flow will go up, right? Huh? Oh, resistance will go up, but the amount of blood that will be delivered will still increase compared to what you had before. Does that make sense? Blood flow to the muscles. Let me put it this way. What are the main regulators in muscles? Metabolic or myogenic? Metabolic. When muscles are active, they produce an enormous amount of CO2, and lactic acid will increase the blood flow. Does that make sense? In the brain, autoregulation. When systemic blood pressure spikes, what happens initially in the first second to the blood flow to the brain? It immediately increases. What is the response from the arterioles? They constrict, okay? And when blood flow decreases, they dilate. Is that myogenic or metabolic? Myogenic. Is there a metabolic component? Come on. If your brain becomes deprived of oxygen, and then you give an oxygen, blood will rush to the brain because it becomes so CO2 saturated. Brain cannot function in acidosis or oxygen deprivation, must have delivery. Does that make sense? Yeah, it works in a certain range. What danger of steep drop in blood pressure? You faint. If blood pressure is extremely high, you have brain edema. Skin. What controls the blood flow to the skin mostly? What is the purpose of blood flow to the skin? Regulation of blood flow to the skin. What do you regulate? Huh? Temperature. Body temperature. That's it. You constrict it when you're cold and you increase it when you're hot. Pulmonary circuit. If certain area of lungs have a lot of oxygen, what's going to happen to blood flow to that area? Blood flow goes up. It's opposite. Once in a while, it's opposite. For pulmonary circuit, blood flow increases to oxygen-rich areas and decreases to oxygen-poor areas. That makes sense? Coronary vessels. When heart is contracted, what happens to them? When heart contracts, they squeeze. There's no blood flow to the heart during a systole, really. So blood flow goes only when the heart is relaxed. Two regulations. Metabolic, right? Heart is pumping hard. There's a lot of CO2 produced. So metabolic, if you're more active, metabolic component will increase the blood flow to the heart. Does that make sense? If your blood pressure drops, what happens to the stretch of the coronary arteries? Decreases. So at this point, what type of regulation will be acting the most? Myogenic. Stretch decreases, and in order to maintain the blood flow to the heart, blood vessels immediately dilate. Heart is critical, right? Oh, when the systole is going on, where does oxygen come from? There's a protein in the muscles. Makes them red. Myoglobin. Remember we talked about it? Myoglobin is the protein that stores oxygen in the muscles. Perfusion. Okay, let's make a picture. I have colors, which is awesome. Red is arterial end. Blue is the venular end. On arterial end, and that's the vessel. Okay. Which pressures do we have? First of all, hydrostatic capillary. Okay, I don't remember the numbers. Screw the numbers. I'm not going to ask you to write the numbers and memorize them, okay? And another hydrostatic pressure is interstitial hydrostatic pressure. I'm going to HPI. It's going to be really low because it's actually what? 0, because everything drains in lymphatics, right? Two other pressures. Osmotic capillary. Where does it take fluid to? From tissues to capillary, right? Does that make sense? It pulls it. And then there's osmotic interstitial, which pulls it back. Okay? Overall, the result at arterial end, net filtration pressure drives the fluid where? In the tissue, interstitial. This one. On the venous end, all the things are the same, right? All the pressures, conceptually the same numbers. Which pressure, the only pressure on the venular end that changes is which one? Hydrostatic capillary, right? Because technically hydrostatic capillary pressure refers to which circulatory parameter? Blood pressure. So blood pressure in the venular end is lower, hydrostatic capillary pressure is lower. Does that make sense? So fluid will go back in the capillaries. Is it going to be the same amount? No. That makes sense? So it's going to be different, it's going to be less. Extra fluid will stay in the tissue and will flush the tissue. Does that make sense? Let's play. If you increase blood pressure, what's going to happen? If you increase blood pressure, which of these four pressures will go up? Hydrostatic capillary. Specify which one. Hydrostatic capillary. What you're going to have as the result of it? Fluid will accumulate where? In the tissues. How do we call it? Edema. That makes sense. If you will block lymphatic system, which pressure will increase? Hydrostatic, interstitial. And what you're going to have? Dehydration of the tissues. Does that make sense? If you will dehydrate the blood, so basically you will increase the concentration of albumin in the plasma, which pressure is going to change? Osmotic. Which osmotic? Capillary. How is it going to change if you increase albumin in the plasma? How is it going to change? It's going to increase the flow from tissues to the capillary. What's going to happen to the tissues? They're going to get dehydrated. Does that make sense? Which organ produces albumin? Second biggest organ in human body. Liver. So if liver fails, the amount of albumin in the blood decreases. Osmolality of the blood decreases. What happens to capillary osmotic pressure? Decreases. Where does fluid accumulate? In the tissues. Do I make sense? People with failing liver will experience edema. Does that make sense? Okay. So we went through this. So this three, absolutely know them. Like, I will ask you something about like system blood pressure increases or decreases. Protein concentration in blood. What we just covered, just know that. That's as far as it goes. Am I clear? Okay. We're going to take a break.